Good afternoon, good morning, good evening, wherever it is, whatever time it is for you. The topic today is going to be hypertensive retinopathy. So when we think of hypertension, which is really common in the US, it's almost uncommon to not have it once you hit a certain age. Hypertension, we don't really think of the eyes. We think of the kidneys, we think of the heart, we might think of the peripheral vessels, the coronary vessels, but we don't think of the eyes that much. Nevertheless, you can get problems, or not necessarily problems, but changes in your retinal vasculature, in your retinal and choroidal vasculature, when you have severe hypertension. When I'm talking about severe hypertension, in quotes, I'm referring to either a severe acute case of hypertension, so like a hypertensive crisis, where your blood pressure is above and beyond that 180 over 110 range, or a patient with chronic hypertension. So that would be like your 70-year-old man who's been taking lisinopril for the last 20 years for mild hypertension. So this can be a problem from severe acute hypertension or chronic hypertension, and it does pretty much the same thing to the eyes. Hypertensive retinopathy itself, though, is not reliably symptomatic. You can, but you tend to not have visual changes with hypertensive retinopathy itself, but its presence, its pathological presence, is indicative of an underlying problem. So this affects both the retinal and choroidal circulation, and the retinal circulation is more inner, towards the middle of the globe of the eye, and that feeds the inner parts of your retina, and the choroidal circulation feeds the very outer retina, retinal pigment epithelium, and then of course the choroid. The retinal vasculature is autoregulated. So what does that mean, autoregulated? What it means is that when your systemic blood pressure goes up or down, the retinal vasculature can expand or contract to keep the blood pressure in the retinal vasculature at a set range. So it's kind of like a thermostat. Now, when the blood pressure goes too high, specifically if it exceeds 110 to 115 millimeters of mercury, the vasculature can no longer auto-regulate itself. So think about it. When your systemic blood pressure goes up, the response of the retinal vasculature is going to be to expand, because when you expand the vasculature, you decrease the blood pressure, and that's the goal. If the blood pressure, systemic blood pressure goes up, the retinal vasculature, by auto-regulating, is going to bring it back down to the normal range. And likewise, if your blood pressure goes down, the retinal vasculature is going to constrict to maintain a normal blood pressure range. When your blood pressure goes up high enough, however, the vasculature cannot expand anymore. And at about 110 to 115 millimeters of mercury diastolic, that autoregulation stops working. It can't autoregulate anymore past that range. So the retinal vasculature is autoregulated, and that's important to remember. The choroidal vasculature, on the other hand, is regulated by the sympathetic nervous system, by the central nervous system, just like all of the other vessels in our body. This is primarily seen in older patients, and the reason is because older patients make up the vast overwhelming majority of hypertensive patients. So there's two distinct disease processes, and those are the acute hypertensive retinopathy, and that can be seen in patients of any age due to sudden severe hypertension, generally those hypertensive crises over 180 over 110, and that can be from many different things: hyperthyroidism, pheochromocytoma, acute aortic dissection, although that would tend to be in an older patient, renal artery stenosis, acute glomerulonephritis, drugs, so things like cocaine, methamphetamines, some of the diet drugs, or a pregnant woman could have preeclampsia and eclampsia. So there's many things that can cause you to have an acute hypertension. But this is acute hypertensive retinopathy is due to a sudden severe hypertension. In contrast, chronic hypertensive retinopathy is seen in older patients. Why? Because older patients tend to have hypertension. And hypertension accelerates the process of atherosclerosis. And as we're going to see when we look at pictures, atherosclerosis is a finding in chronic hypertensive retinopathy, but it's not a finding in acute hypertensive retinopathy. So with atherosclerosis, the retinal arterioles are going to expand and they can compress venules, and that can lead to occlusion. So that can be problematic as well. So go back to thinking about why the vessels might expand or contract. You can imagine that if you have an occlusion in an arteriole, that arteriole is going to expand. Why does it expand? Because it needs to decrease the resistance, because the plaque has increased the resistance by decreasing the luminal space. All right. So acute hypertensive retinopathy, this is also referred to in the literature as malignant hypertensive retinopathy. However, since a lot of patients are now becoming aware of malignant tumors, we try to not use that word outside of cancer. So it's acute or malignant hypertensive retinopathy. Acute hypertensive retinopathy is typically seen in patients in a hypertensive crisis, as mentioned. Generally, the blood pressure has to be above 200 over 110 to cause retinopathy. But the important number is that diastolic number. Once you pass 115, there's no autoregulatory mechanisms left in the retinal vasculature, and you can start to see changes. Causes of secondary hypertension include things like hyperthyroidism, pheochromocytoma, preeclampsia, drug abuse, and neoplasia. Elevated blood pressure causes direct damage to the retinal and choroidal vasculature, and that's called fibrinoid necrosis. When you have severe hypertension, you get damage to the smaller vessels, and that can subsequently cause ischemic necrosis. So this can manifest as many things. First off is the cotton wool spots, and cotton wool spots is caused by ischemia to nerve fibers. And that's secondary to the ischemic necrosis from the fibroid deposition, which comes from the hypertension. So what happens here then is you get decreased axoplasmic flow because the nerve fibers are ischemic, and that decreased axoplasmic flow eventually leads to swelling and then opacification, and that's what those cotton wool spots are. Remember that the nerve fibers are the innermost layer of the retina. They're the ones closest to the ones. If you're thinking about, try to explain this. If you're thinking, when I say innermost, if you're thinking about like a ball, like a basketball, the inner part is the part you don't see. So it's the inner layer. And that's where the nerve fibers are. You also see uniform narrowing of arterioles. Why uniform? Because acute hypertensive retinopathy is not caused from atherosclerosis. Atherosclerosis does not play a role in acute hypertensive retinopathy. So all of the arterioles are going to be narrowed from the hypertensive retinopathy. Now, I imagine you're probably asking, I thought you said that the retinal vasculature expands when the blood pressure goes up. And that's true, it does. But once the blood pressure passes the threshold, that 110 to 115, remember that autoregulatory mechanism no longer works. And now all of those chemicals, be it epinephrine or whatever the cause is that's causing the hypertension, now it can do its direct work and constrict those vessels. And that's what epinephrine and various other chemicals do. Some other things that you can see are hemorrhages, so flame hemorrhages and dot blot hemorrhages. They're a little bit different, but for the most part, you don't really need to worry about that. Flame hemorrhages are necrotic vessels in the nerve fiber layers, and dot blot hemorrhages are necrotic vessels hemorrhaging into the inner retinal layers. You can also see papilledema, and that's caused from leakage from the arterioles that supply the optic disc. So when you have elevated blood pressure, that increases the flow of fluid out of the vessels, and that mechanically causes fluid to flow into the optic disc, and that causes that papilledema, optic nerve swelling. And then there's another thing called Elshing spots, and this is particular for acute hypertensive retinopathy. And Elshing spots are just these little black spots, and this is caused from damage to the retinal pigment epithelium. They're these little black spots that have these surrounding halos. And these are typically associated with acute hypertensive retinopathy, although I'm not sure if they're completely pathognomonic. Okay, so here is the patient with retinopathy, hypertensive retinopathy. So see if you can guess what some of these things are. So there's a cotton wool spot. Cotton wool spots look like clouds. So you can see this looks like a cloud, right? Yeah. These are hard exudates. So these are just like yellow flecks. You can see these in hypertensive retinopathy as well. And then you have flame hemorrhages. Flame hemorrhages look like they're kind of feathered out, whereas when you see the dot blot hemorrhages, I'll show you that in a little bit, dot blot hemorrhages are more like the name implies, dots and blots, whereas these are feathered out. They're kind of like finger painting, like you smeared it a little bit. All right, here's another one. So there's a dot. This is probably a dot blot hemorrhage. There you have some cotton wool spots here, here, and here. And then papilledema. So important when you're looking at optic disc swelling, the good way of knowing that you have optic disc swelling is the fact that you can't really see the margins of the optic disc. So it's swollen and it's kind of confluent with the rest of the retina. You don't have this really distinct border of the optic disc. So this is papilledema here. Okay, now this on the other hand, you can see the optic disc. But there's other things wrong with this. And that's the Elshing spots. So these Elshing spots are damage to the retinal pigment epithelium, and you get these sort of pigmented nodules, and then there's a surrounding halo around it. Okay? So you see them all the way around here. Tortuosity, you can also see. That's pretty nonspecific, but that's another feature. How about this one? So there's optic disc swelling. You could probably say that this is the optic disc here, but the margins are a little bit confused here. So you could probably say there's a little bit of optic disc swelling here. I'm not sure if these are cotton wool spots down here. They look kind of puffy. That's why I put a question mark down there. I'm not exactly sure. These are dot blot hemorrhages. Dot blot hemorrhages are typically just these small little pinpoint hemorrhages. And then, of course, flame hemorrhages. These sort of smeared out looking hemorrhages. And then this is a hard exudate. So what do we do for acute hypertensive retinopathy? We really don't do anything for the retinopathy. What we're more concerned about is the hypertensive crisis. And I talk about that in the cardiology lectures, and probably talked about it to a lesser degree in the endocrinology lectures. But we're more concerned about the hypertensive crisis because that can kill the patient. The eyes Well, a patient doesn't need their eyes to survive. So really, when you're dealing with a patient with hypertensive crisis, you're not worried about the eyes. The way you can diagnose this, if you do want to look at their eyes, is either clinical presentation or an ophthalmoscopic exam, although we're not going to do any significant workup for the patient with acute hypertensive retinopathy as far as the eyes go, because there are other things that tell us: their blood pressure, whether or not they're sweating, and so forth, whether they've used drugs. So the underlying cause should be sought based on the patient's history and other symptoms. The treatment is to manage the underlying cause, and I warn you not to reduce the blood pressure too precipitously because you can worsen the damage. So you want to reduce the blood pressure gradually. Some common complications that come out of acute hypertensive retinopathy is a retinal detachment, and this is due to damage to the retinal tissue, and it's because of the exudations in the choroid and retinal pigment epithelium that can cause some traction in between those two tissues, and if the retinal pigment epithelium becomes compromised, you can get a retinal detachment. So you have exudations in the choroid and retinal pigment epithelium, particularly these back here, these Elshing spots, and these spots can be a place that the two layers can get traction, and from that, then you can get detachment. You can also get retinal detachment because of the elevated blood pressure leading to fluid moving out of the vessels and into the tissue. That can cause an exudative retinal detachment. So various ways you can get retinal detachment. Acute change in vision, usually peripheral, photoxia, those flashing lights, and a new onset of floaters would be consistent with retinal detachment. Optic neuropathy is caused from ischemia of the optic nerve head due to vasoconstriction. And with optic neuropathy, you'll typically have a blurred disc margin, papilledema, and flame hemorrhages. But remember, with optic neuropathy, you'll also have problems with vision, problems with moving your eyes. A lot of times with optic neuropathy, moving the eyes is painful. So when you do that visual field test, or you tell them to follow your hand, they may have some pain in moving their eyes in certain directions. So that would be a sign of optic neuropathy. Chronic hypertensive retinopathy is the one we see more often, and chronic hypertension accelerates the development of atherosclerosis, and it's atherosclerosis that's really the problem here. So they kind of are partners in crime. Hypertension is what you get first, the primary hypertension, and then the atherosclerosis kind of comes in with that, because hypertension leads to atherosclerosis. Not the only thing, but it's one thing that really helps you develop atherosclerosis. It's the atherosclerosis that's really problematic in chronic hypertensive retinopathy. In the very far advanced form of chronic hypertensive retinopathy, you can start to get loss of acuity. Atherosclerosis reduces the radius of the arterioles, and so the vasculature has to expand to downregulate the resistance. We kind of talked about that earlier. Another thing, though, that is worth remembering is that the arteries, arterioles, and the venules, they travel together. I don't think they travel together in any kind of sheath, but they travel together. And when the arterioles, actually, you know what, I think they do travel in a sheath. Don't quote me on that. But either way, when the arterioles expand, they can compress the venules. And when you get atherosclerosis, the arterioles have to expand to reduce resistance and allow blood to reach the rest of the retina. And so by getting arterial expansion, you can get compression of the venules, and when the veins are compressed, essentially what you now have is a brain retinal venous occlusion, a BRVO. And so that can lead to, that's a big complication of chronic hypertensive retinopathy. So what are the manifestations of chronic hypertensive retinopathy? Focal to uniform narrowing of the arterioles. The narrowing is going to be specifically seen at regions of plaque. However, as this develops over time, it's going to become more focal, but it doesn't have to be focal. Another thing that you see, which is a hallmark finding of chronic hypertensive retinopathy, is AV nicking and AV crossing. And it's the AV crossing that's a little bit easier to see when you're looking at a patient's retina. And so this is caused from arterial compression on venules, and it's exactly what it sounds. The artery will cross over the vein. I'll show you a picture of that. You can also get flame hemorrhages and dot blot hemorrhages due to fibrinoid necrosis. You can get what's called copper wiring or silver wiring. They're different, but this is directly from the atherosclerosis. This is just what you're seeing here is the narrowing of the vascular lumen due to atherosclerosis. And finally, you can see a macular star. That's caused from exudation around the macula, and this is more in the severe cases. Okay, so what was I talking about here? This is an AV crossing. So here you have one right here. See, these in a normal patient, you shouldn't have this. You shouldn't have these vessels crossing over one another. And you see another one here, and you see another one here and here. So there's AV crossing. That's a sign of chronic hypertensive retinopathy. This is copper wiring here. So you might want to pause it after I'm done explaining this and then bring it up to full screen so you can see it better. But if you look at this vessel compared to the vessel next to it, you see here is this little line, this sort of copper-colored line that is traveling through what appears to be the middle of the artery. And that is what's known as copper wiring. And this is just, what you're directly looking at is the narrowed lumen due to atherosclerosis. This is copper wiring. You can also see it on this artery here. You see it on this artery down here. See it down here and here. So copper wiring. So here is an example of AV crossing here. I didn't know if this was the best example, but AV nicking is where you get an indentation on the venule from the compression. So if you have AV crossing, that's good enough. AV nicking is a little bit harder to see. And then here's copper wiring. So you can see that little line moving through the artery. And then this here is silver wiring. Silver wiring is a more severe occlusion and up to 100% occlusion, and at that point then it becomes totally necrotic and starts to turn white, and so that's why it's silver. Silver wiring. So what do we have here? Try to point out the problems here. I'll let you pause it. Okay, so we have, of course, a cotton wool spot. They look like clouds. Certainly have copper wiring right here. These little lines going through the arteries here and here. They kind of look like midlines on the road. And you have AV nicking and crossing. Here's my better picture of AV nicking. So you see here how there's that little indentation in the right here. That's AV crossing, or AV nicking. But if you see this copper, or especially silver wiring, and you see crossing, that's, along with a consistent patient history, you've essentially made a diagnosis of hypertensive retinopathy. Okay, so this is the macular star. And all this is just exudations around the macula. Remember, the macula is very highly vascularized. So any place where you're highly vascularized, when you have hypertension, you're highly likely to get exudation, transudation. out of the vessels. All right, what is this stuff here? Okay, so here you got blue. This is the cotton wool spot. The green here is pointing to the macular star, and the white is pointing to a dot blot hemorrhage. And these hemorrhages have an affinity for the macular area. A lot of times you see these in the macular area. And I didn't actually point it out here, but this is copper wiring right here. And you got AV crossing too. All right. So if you know this stuff, you are going to be set for the USMLE. They don't touch on ophthalmology a whole lot, and what they do touch on is the basics. But if you know this, you know more than 95% of general practitioners that are practicing right now as far as hypertensive retinopathy goes. So what do we do for chronic hypertensive retinopathy? Well, first off, we need to keep in mind this patient population. So patients with chronic hypertensive retinopathy, just by the fact that they have chronic hypertensive retinopathy, that it's gotten that bad, they are categorically at a 7 times risk for stroke, a 4 times risk for MI, a 3 times risk for coronary artery disease, and a double risk for peripheral artery disease. They also have an increased risk of age-related macular degeneration. Risk factors, in addition to age, which is really the big one, blacks tend to have more of a likelihood to develop this than whites. Also your family history, smoking, obesity, stress, sedentary lifestyle, excessive alcohol consumption. What we do for this is we treat the hypertension. Common complications out of chronic hypertensive retinopathy are retinal vein occlusion, and that's exactly due to the AV nicking and occlusion. This, if it's severe enough, will lead to visual field deficits. Retinal detachment, this is due to vascular fibrosis, and that's the cause of tractional retinal detachment. Optic nerve atrophy can happen from if you have a chronically swelled optic disc. What I'm thinking is because of the swelling, you get compression on the arterioles, and so you don't have enough vasculature, you don't have enough blood going to the optic nerve. But chronic optic disc swelling will lead to optic nerve atrophy, and the result of that will be decreased acuity because it's the optic nerve that transmits all those signals to your brain.